I want to go back to what you were saying about how amazing it was to have an oral formulation of this. In my practice, I've historically most been familiar with methyl naltrexone sub-Q, which in the inpatient setting has just been wonderful. I use it with a high degree of confidence. But a lot of our patients want to avoid getting to that point. They want to prevent this from becoming a lifestyle-affecting issue for them. And so the other oral agent, oral methyl naltrexone, is also a very effective PAMORA. Rick, would you mind telling us a little bit about the study data and efficacy and safety of that?
Right, so you're right, the sub-Q came out long before the oral. There were some issues with just getting it into the right formulation for the oral formulation. They ended up using sodium lauryl sulfate, which turned out to be the magic sauce, it seems like, that made the oral work that way. So the trials that came out then, they were designed a little differently than some of the others that subsequently came along, and that was in part because FDA was trying to define what we talked about earlier, endpoints and how to look at opioid-induced constipation. As it turned out, the phase 3 trial with Relistor oral was something that looked at that quantitative measure. That is, that you had at least 3 spontaneous bowel movements and at least an increase in 1 spontaneous bowel movement per week in 3 of the 4 weeks that it was under double-blind conditions. So the trial had a 4-week double-blind phase where everybody took it once a day, and then there was actually an 8-week open label where patients took it. I'm not sure that was open label in 8 weeks, but they took it as needed, so it was on a PRN dose, a little different than the other trials. Then there was a safety trial, safety component that was looked at as well that we published on. So the efficacy, it did separate nicely and very robustly from placebo in the double-blind phase and as a primary endpoint. It also had some very nice separation on a lot of the secondary measures that were looked at. I think the one that stuck out the most to me and was maybe the strongest where it looked at rescue-free bowel movements within 4 hours after dosing. And so with Relistor compared to placebo, and this shouldn't surprise you, David, you used the injection a lot. We used to talk about how reliable and rapid the response was after sub-Q injection. Similarly with oral, within 4 hours, the percentage of patients who had a rescue-free bowel movement was strongly and statistically different than the placebo group in that setting. The safety data was very promising, I think partly as Jeff and Brett both alluded to with the lack of interaction with SIPs. That certainly did not cause the problems. A little bit to your point, Jeff, on blood levels, it's not always what maybe happens in the gut, but we know that all these drugs can be prone, if there's increased blood levels, to reversing analgesia in the brain. That certainly was seen in a very nice dose response with naloxegol and a little less with nalmefene, but certainly can be there. This drug didn't seem to have that in the studies that they looked at from a safety standpoint, and then also the cardiac safety, which the very first drug I ever studied in this class was albumipan, which never made it to market because of a cardiac marker that people still aren't sure about. But anyway, the cardiac safety profile with methyl naltrexone was very much the same as placebo, so no cardiac signal at all in the trial.
You talk a little tiny bit about onset of action. I work in an emergency department. It's all about throughput. Sorry, that's a bad pun. But I actually initially liked the sub-Q because I thought it worked quicker. But the truth of the matter is I've gone mostly to oral in the emergency department as long as nausea is not an issue, and have been happy with results.
And I think one point there for all these drugs, we should probably mention, Steve, as you know, is that in patients, though, where you suspect really a complete bowel obstruction, and particularly if they're in the ER, none of these drugs are indicated, in fact, are contraindicated. They need a workup, and that make sure that there's not a bowel obstruction in that scenario.
I'll add into that because it takes the acuity, it kind of changes the acuity level when prescribing inpatient versus out. Outpatient, they're not vomiting. I feel pretty confident we don't have a bowel obstruction. Inpatient with oncology patients and other patients, you're dealing with just a different population. And again, more of an acuity. So you really think second, what are we going to put them on? And is there any potential for obstruction because it's a different population? I also think how the formulation matters as well. Inpatient, somebody's going to give them the injection and they're getting other injections. Potentially they're getting Lovenox or something else. Therefore, injection's not an issue. But outpatient, you mentioned them taking home a syringe and they said, I can't do that, or I don't have anybody to give me that shot. Even though it's easy, we all think it's easy, but to a patient it's daunting. And so therefore, yes, an oral formulation. I've had a lot of people very quickly say, well, clearly their constipation isn't that bad. I don't know that it's better or worse, but again, it's a daunting task to take sometimes a syringe home. Now, others prefer that. And we've said the syringe and injectable, yeah, you can kind of take it to the bank of how quickly it's going to work as opposed to the oral. But so there's pros and cons to both. It's great to have two options.
Did you have anything to add to that, Teresa, in your practice?
I completely agree with what my colleagues and panelists have been talking about. I was actually really excited when the oral formulation came out. Very, very excited, because I did feel a lot of resistance in my patient population on the outpatient setting to want to use the syringe. However, what I found in clinical practice is that the injectable formulation is a lot more predictable. And actually, to the point about patients being fearful about wanting to go out, being anxious about when their bowel movement's going to start, they really enjoy the option of being able to know, and get it over with and get on with their lives. So I really leave it up to the patient to decide. And so, I do the education that I need to do. If all else is equal in terms of insurance, then I'm very happy with whatever their decision is. In the hospital, it's my go-to is the injection formulation. I don't even think we have the oral formulation on formulary. And again, it's in the right patient situation. If I'm not worried about obstruction, I know that I'm going to be 100% effective. And so the injection formulation is really what I count on in the inpatient setting.
And I would say also as in the outpatient setting, oftentimes it's driven by payer source. So very likely you may have an option or have a choice or wish to use a different one, but we're oftentimes directed in the outpatient setting.
I think we're going to talk about
what
financials.
coverage is, and we're going there, yes.
I would echo your experience, Teresa. I think keeping somebody around in the hospital, waiting for them to have a bowel movement, is certainly an undignified way for them to spend their time. So I introduce the option early. I don't sit on it too long, and after I've proceeded through my usual treatment workflow, I'd love to give them the chance to have a satisfying bowel movement. I do always warn them, though, that it can come very quickly.
Yeah.
So I make sure that we have a commode nearby.
Yeah, and that's the benefit. And then you can follow that up with a prescription for the oral formulation when they go home.
Exactly.